I want to thank everyone for being here tonight. Welcome to the Prostate Cancer Awareness Event, hosted and sponsored by the NAACP branch here in the city of Brockton, as well as AdMeTech. The fact that all of you are here tonight speaks volumes to your commitment with respect to the power of community awareness and the call for action. Tonight, I'm among friends who are committed to saving lives. But tonight, we are not here to talk about science or technologies. We're really here to talk about how we can impact making sure that the awareness the awareness with respect to the prevention of cancer is out in our community. Thank you for joining me in this mission. I apologize for being a little tongue twisted. I've given two conversations today on various topics, but I'm glad I am among friends. So I'm Tony Branch. I'm going to be your host tonight, former chair of diversity for the city of Brockton, as well as the first vice president of the NAACP for this area. And I must say that I've been hosting this for a few years. And as a result of hosting this, I have become a steward of this knowledge, which is really, really important, especially with respect to now my own personal journey with respect to my own prostate. And I can tell you that the information that has been given has been on the money. And it has made me more comfortable in having my conversation with my PCP, nurse practitioners, and others. So again, I am very, very happy to be here tonight. I want to first acknowledge the state legislative delegation. So we just want to acknowledge their commitment with respect to cancer education, high-risk men, Black and Latinx, and they have made it a priority to make sure that there are funding in that vein. And so I want to make sure that we acknowledge perhaps they will join us later. But I'm going to just, go into talking about my boss, President Phyllis Ellis. I will ask that Phyllis give us some remarks. And I can tell you all that Phyllis Phyllis should be a doctor on this. She makes sure. Do y'all go to your appointments? I know that she has conversations with men members of our organization. And Phyllis, we just want to tell you that we love you and we really, really thank you for your strong leadership in this area, because it really makes a difference. Often we have to hear that in our ear, whether it's our spouse, our partner, or whomever, or that motherly love or that auntie love that Phyllis gives to make sure that we are doing the right thing. Ladies and gentlemen, Phyllis Ellis, president of the Brockton branch, NAACP.
Well, thank you, Tony. And good evening, everyone here on the Zoom and those who are watching live on Facebook as well. I just want to take a few minutes to talk about the Brockton NAACP and this long-term partnership with AdMeTech and what it has meant to our branch. We started out in 2014 when Steve Bernard was the president, and the first prostate cancer meeting was held at Lincoln Congregational Church. And Brockton was chosen because at the time, Brockton had the highest mortality rate among Black men. There is always a question of why, but I personally think one underlying factor is the lack of knowledge about prostate cancer. Dr. Stern and her team at AdMeTech and prominent doctors like Dr. Wason, who is here with us today, have brought prostate cancer awareness to a new level. The focus is on knowing your risks, learning advances in patient care, and to basically take charge of your health. Our branch holds about 2 events per year. And at every event, we are always joined by knowledgeable doctors and who specializes in prostate cancer and who brings their expertise to us in terms that we can understand. And today in 2024, Brockton is not considered the highest rate. And I think that is due because of these programs that we have. Initially, the Brockton branch was the only branch holding prostate cancer awareness events, but Dr. Stern has partnered with other NAAC branches to bring about this very important information, and it has been proven beneficial. So I would like to take this opportunity to thank Dr. Stern and AdMeTech, Thomas and all the others, and all the doctors for their partnership. And I truly hope this partnership will last for many, many years to come. Their dedication has made a tremendous impact in the field of prostate cancer. I also would like to thank Mayor Sullivan, who has been with us at the outset, and he never hesitate about coming on and talking about prostate cancer in any event that we hold. So thank you, Mayor Sullivan. And also to the delegation, Senator Brady, State Representative Jerry Cassidy, Michelle Dubois, and Rita Mendez. And a special thank you to our health committee, Janet Trask, who is the chair, Stephen Bernard, Leona Martin, and Tony Branch, our first vice president, and an excellent host. In closing, though, I would like to give a shout out to our branch. Our branch has been around for 70 years, and our mission is to achieve equity, political rights, and social inclusion by advancing policies and practices that expand human and civil rights, eliminate discrimination, and accelerate the well-being, education, and economic security of Black people and all persons of color. We will be celebrating our 70th anniversary on November 16th. We will talk about the history of our branch, but more importantly, we will be celebrating our veterans. So I hope you guys can attend. Tickets are on sale now on our website and also through me. So thank you very much for attending tonight, and back to you, Tony.
President Ellis, thank you for that excellent presentation. And again, as you mentioned, this is really about awareness, and this is about our fight against this disease. And again, we want to acknowledge your leadership. But let me just say this: it doesn't stop with AdMeTech or the NAACP. It speaks to the greatness of this municipality, the city of Brockton, and its leadership under Mayor Sullivan. So I'm going to bring it to you. Mayor Sullivan has been at the forefront of helping us in this fight. And you might notice that he's a white guy, but it doesn't matter. Because we know the disease affects Black men, Latinx, but you know, Bob Sullivan, Mayor Bob Sullivan, has been a really steward in this work, and we hug him and appreciate him. And I know that he has some remarks tonight, so I just want to introduce Mayor Robert F. Sullivan, City of Brockton.
Thank you, Vice President Branch. I want to thank President Ellis and all the membership of the Brockton area branch NAACP that does unbelievable work, not just in Brockton, but beyond the confines of the City of Champions. I want to thank AdMeTech and Dr. Stern and all the doctors. This came to my attention by Steve Bernard. Steve brought it to my attention many years ago when I was a counselor at large, and I was not aware of the disproportionate numbers of men of color coming down with fatal prostate cancer. And so Steve came before the city council when I filed the resolution to resolve, and he educated and informed all of us. And so I'm fortunate to be here. My dad is a prostate cancer survivor. I have urged everybody that I know to get tested. Some people say, no, it's an embarrassing test. It's a test that can save your life, and that's proven. So get your PSA number counts, go to your primary care physician on a regular basis, and get your prostate examined. You need to do that. You need to do that for yourself, but also for your loving family and friends. And so I really thank President Ellis and all the membership, because this is an important conversation that we have, and we need to continue to have it, because the proof is in the pudding. People are being saved by education and by listening to the medical experts, but listening to people that are cancer survivors like Darren. You're going to hear from Darren and Chief Brian Nardelli, who is a cancer survivor, a prostate cancer survivor. Wow. I think at the end of the day, we as a community are all about collaboration. And this is the greatest example of collaboration, coming together on a Thursday evening to be able to live stream this, talk to the professionals, but also talk to people that have come down with the deadly disease but fought against it, with the support of medical experts, but also with the support of friends and family. And I want to thank President Ellis for her leadership, but I am just so proud to continue to work for all of us here in the City of Champions. So again, thank you very much for having me on. God bless you all, and I will be there for the 70th anniversary. Thank you very much, President.
Mayor Sullivan, you're awesome. Thank you for that great presentation. And he broke the mold tonight. I mean, he's mentioning not only that his dad, but others, our fire chief has been impacted by prostate cancer. So again, although our focus has been, because we know what statistics have said over the years with respect to those of African descent, Latinx community, but again, it's impacting all communities of men. And so we thank you for, and I'm going to call it, I'm a church guy, that testimony. And thank you, Mayor Sullivan, for that. So listen, I don't know how to introduce Rasan Hall. I don't know how to. He's a very tall man, handsome. He wears the bow ties better than anyone else. He has what I call a towering voice. But let's just say this: he is the president of a very important organization of the Massachusetts Urban League. We know that the Urban League is celebrating, I believe, and Rasan, you can push back on me, 105 years committed to civil rights. Ladies and gentlemen, President Rasan Hall.
Thank you so much, Bishop Branch. One of the things that you left out of the introduction is that I'm a proud member of the NAACP in Brockton as well, but that's okay. I counted to your head.
Noted.
Thank you both to the NAACP for hosting this session, and for AdMeTech for being a great leader in this space. I'm proud to announce that the Urban League of Eastern Massachusetts is partnering now with AdMeTech to continue to spread the word and raise awareness about the significant impacts of prostate cancer, and to raise awareness to address some of the equity concerns that exist. And it's great to have partners in the city, Mayor Sullivan, as well as the rest of our city's delegation. I'm reminded of a quote by the Reverend Dr. Martin Luther King Jr. He said, "Of all the forms of inequality, injustice in health is the most shocking and inhumane." And when I think about the conditions of our community now versus the time when Dr. King was living, there are certainly a lot of things that have improved, and certainly a lot of strides that we have made. But there are certain areas where there continues to be a great and staggering distance. And one of those areas is in health outcomes, and particularly when it comes to prostate cancer. And that is why it's all the more important that we do this work of raising awareness, but also fighting against injustice. These disparities don't exist merely because of biology. There are other factors at play that lead to these disparate rates. And when we talk about the social determinants of health, where people live, what type of employment opportunities they have, the education, the environmental contaminants, Black and brown men are disproportionately found in higher concentrations in the areas and conditions and situations that lead to greater health concerns and conditions. And so it's one thing to look at what is happening in the system, and we have to fight against those things, but it's also incumbent upon us to do our part, to take care of ourselves and to get tested. It is a function of our desire and will, and a function of how much information we have access to. I know that we are at the point in the year where if I see one more political ad, I will lose my mind. And we're not even in a swing state. But just imagine if there was that much investment and energy and desire to raise awareness about prostate cancer and the disparities in the rates of prostate cancer or prostate cancer deaths. We would see a significant shift in health outcomes. And so there aren't hundreds of millions of dollars being poured into ad campaigns around prostate cancer, but the same level of passion that we have for supporting a political candidate or for preserving our democracy is the same level of fervor that we should bring to raising awareness, because it's really about saving the lives of people who we love. We all know people who have been impacted by this disease and people who have succumbed to this disease, but more importantly, people who have survived it because they've gotten tested and they've spread the word to other people. So it is on us to do the work. Doing that work means being an example, getting tested ourselves, encouraging the people, the men in our lives to get tested as well, to spread the word to more people, but also to take care of ourselves. And so the saying in scripture says, as iron sharpens iron, so does one person, or in this instance, one man sharpens another. So let us be models, let us be examples, let us spread wisdom and information and inspire and encourage everyone so that we can defeat this disease. So thank you.
Thank you for that awesome presentation. We really appreciate you, proud member of the NAACP, President Hall. So I'm looking down. I see that from the iPad that we have Mr. Roberts on. I'm so glad that you're here. I'm going to go with you now. Mr. Roberts is going to present his testimonial on his experience with prostate cancer. We want to hear all the information that he has to share. And always, and Deb, is that you over there?
Yes, it is. Hi, everyone.
Hello. So it looks like you all are ready to go. So, ladies and gentlemen, the Roberts family, God bless.
First of all, I wanted to thank AdMeTech and NAACP Brockton for inviting us to talk again. We've been on your show several times over the years, and we know the importance of sharing our information, telling our story. We are a family of prostate cancer survivors. We are both, Charles and I are both public service servants, and just stop what we're doing to share our story, because Black and brown men are 2.5 times more likely to die of prostate cancer. So we're trying to encourage all to have prostate cancer screening. It's so important. I wanted to also share some of the things that we're doing and how we're increasing our network. I'm currently in my second term of being on the Town of Stoughton Select Board. I am the interim president of the Massachusetts Municipal Select Board Association. I am the chair of the Stoughton Equal Opportunity Committee. I just had worked with the town where we gave Frederick Richards, the Olympian gymnastics bronze medalist, the key to the town of Stoughton, and we also represented the key to the town at the Gold Over America event at TD Gardens, and we are reactivating the Blue Hills NAACP chapter. So we're doing a lot to increase our network. I'm also Delta Sigma Theta. I support my sorority sisters. So all of this work to increase our network so we can spread the word about screening, pre-screening for prostate cancer. Charles, can you please tell the audience about your network, your retired police officer, law enforcement officers that you're sharing your story with and encouraging pre-screening, and your friends and your family, and also and you're part of a fraternity as well.
Yes, I'm a retired police officer from the Stoughton Police Department, the town of Stoughton. I've been retired about 9 years now. They discovered, or it was discovered in my annual physical about 4 years ago. Well, actually, 4 years ago, back in November of 2020, when they discovered that I had prostate cancer. I was at stage 2, so they were able to come up with some options for me. I started treatment in January of 2021. I completed chemotherapy in June of 2021. I also had hormone treatment and radiation treatment. Hormone treatment started in February of 2021 and ended in August of 2022. Also, I had radiation treatment, which started in May 2021 and ended in July of 2021. Right now, I'm still in the area of the cancer. I have to meet with my radiation oncologist every year, and my hormone oncologist twice a year. So I got another 2 years to go. So it'll be sometime in August 2026 before they completely release me from what's going on. I am still, to this day, every time I go in, I'm still cancer free and it's undetectable. So whatever they gave me worked out pretty good, but it had a lot of negative effects. I'm still recuperating from the treatment. I'm getting better every day, though. My energy level is increasing slowly but surely. And like Deborah said, I'm also a member of Kappa Alpha Psi fraternity, Divine Nine, and I work as much as I can, in terms of I have a part-time job. I don't have a full-time job, but I'm enjoying retirement. But it's a lot of stress going through the treatment, and the recovering from the treatment is probably a little bit more work than the actual disease itself at the time. But that's about it. But like we're out here to contribute what we can to helping other people, and whatever we can do.
Thank you, Mr. Roberts. And Dr. Stern and President Ellis, I think you all give me a little some freedom here to just ask some questions, because we're actually doing very good in time. One of the things that I wrote down for today is based upon conversations that I have had with folks around mental health. And one quote that an individual said to me, he said, "Bishop, I feel miserable to morbid because of this disease." One of the things, Mr. Roberts, you just mentioned, you talked about sort of the emotional piece of this. So I just want to ask, is there emotional support? Is that something that we need to, naturally we need to focus on, but I think it's more acute than what folks are talking about. And I'm kind of wondering, especially for men that are single, that don't have a partner, that don't have, I wrote down here, this disease is really about fathers, brothers, son, partners, and friends, but it's really about where is the emotional support for a person that feels miserable to morbid? Can we kind of delve into that a little bit?
Well, fortunately for me, most of it is coming from my immediate family.
Yes,
my wife and my children, who are not children anymore, but most of it comes from there. I have a lot of brothers and sisters and a lot of family, immediate family and extended family in the area. So a lot of that comes from there. But like I said, a lot of the organizations that we belong to, we get a lot there too. And like I was saying, we're trying to reach out and help people and let people know there are other organizations out here that can help you along with it. A lot of people just aren't doing anything about it when they realize what they have.
Right. Mr. Roberts, can I just ask you a follow-up? And I have to ask this because it's something someone was saying to me the other day when I told them I was hosting it this year again. Can you define to us, or even you, Deborah, what does a good day look like for you?
A good day looks like is when the sun is out, it's nice outside, and you feel a little energetic when you get up out of bed.
You can leave it.
For me, a good day was seeing Chuck throughout this whole journey, and how at a point in time he can barely walk like a block or 2 house lengths without having to sit down and say, "Wait a minute, Deborah, I'm just a little too tired."
Right.
So now he can walk a longer distance. He's going to the gym and he's smiling more. That is a good day.
Right. So thank you all. Listen, thank you all for your testimony. And thank you all
Tony,
for,
can I chip in?
oh, absolutely.
Yeah. First of all, knowledge of resources available to men who feel the way the men described to you, morbid, right?
Yep.
First of all, you're welcome to refer this man to us because we have access to resources such as, for example, the support groups, prostate cancer support groups. Okay, and this is really important. These are peer groups. Sometimes they're led by other men survivors. Sometimes they're led by physicians or nurses. And this is a very important resource of support. And why it is so critical, Tony? Because unfortunately, a couple of years ago, there was a publication that showed increased rate of severe depression, including suicide, in men who are diagnosed with prostate cancer. So it's attending to mental health wellness in the face of prostate cancer diagnosis is extremely important. And support groups would be very high up on the list for men to learn about.
And so, and the follow up to this, I guess, if you go into anyone's medical practice, whether it's Atrius, what is it called, Manogram, so this really this emotional support should be a part of the clinical plan. Is that accurate?
I think it is really important, and particularly support groups.
Gotcha.
When men come together and men support each other and men share what's happening, very frequently what has devastating consequences is not able to open up. If you do not open up, you will not get the support that you need. And so support groups is the environment when that is very important for men's recovery and coping ability.
Dr. Stern, so you said something very important. The opening up. So obviously I'm a man, and there's a lot of men on this in this event right now, but we don't like to open up.
I know.
I mean, push back on me if anyone disagrees. We don't want to talk about it.
Yeah.
And I hear you. And again, this is good information that needs to get out there. And this is what this is all apart in terms of getting this awareness out here. So thank you for this. At this time, a very important figure in the city of Brockton, but I'm gonna go further. And Darren knows I'm about to introduce him.
Actually, I didn't, but
you didn't? Oh, you're next. So if you all don't know Darren Duarte, I've known him, not him personally, but I was forced to watch Darren. He knows the story. My mother always talked about Darren. He was on the various shows in the city of Boston. I consider you to be a national hero, a national journalist that has really brought home a lot of information over the decades that you were a journalist, not only in this Commonwealth, but across the country. Darren Duarte is currently the Director of Communications for the Brockton Police Department, but more importantly, he is a survivor with a testimony that we all should listen to. Ladies and gentlemen, Darren Duarte.
Well, thank you, Bishop, and thank you, Dr. Stern, and thank you, Phyllis. You know, you guys have done wonders for this community, and I'm not shy about saying you have done wonders for me. And I want to tell folks who are listening right now, when I first started going to these events, they were in person. And Phyllis would ask, or the bishop would ask, or Steve Bernard, come on down. And I would go, maybe like some other men. I would listen, didn't pay much, paid attention while I was there, but no follow-up. Why? Because I didn't think something like that could happen to me. It just wasn't on my mind. I didn't think about it. And was I going to, because I didn't want to say no to my friends? I don't know. But after a while, I'm thinking to myself, these people are not doing this, for nothing. This is important. So I go and get checked, and there's a whole big story with this, but I got to tell you, eventually it comes back that I have an serious aggressive form of prostate cancer. And that if we didn't act fast, say within 30, 60 days, because it seemed like it was confined to the organ, and as long as we can keep it there, as everyone here knows now, doctors, that's best. You don't want it to get out into the bloodstream. So luckily, if I did catch it in time, I wouldn't have to go through chemo, I wouldn't have to go through radiation. And so that's what happened. But if I hadn't been coming to these events and talking to you folks, my surgeon said within 5 to 6 years, if I had done nothing, I may not be here. So that's one of the things that I want to stress to people, is that, yes, when you hear people tell you about these things, it's serious, and it's a disease that if you catch it early, you can be fine. But you have to do something about it, and not to be afraid to talk to your doctor or talk to your family or your friends about it. One of the things that did happen to me, though, and this is not everyone's story, is that there are times when, because in my case, I had to be my own best advocate. And having you all there in my corner also helped. What do I mean by that? I was going along and seeing a specialist, and at first just relying on everything that they said to me. And there didn't appear to be anything urgent on the doctor's part. I mean, my PCP sent me off to a specialist, and so I'm just following the specialist lead. And eventually, after talking to folks and finally looking at my different scores over the so many months, you all tell that looks pretty bad. Are you sure your doctor's not doing? You need a biopsy. And I kind of forced the issue with my specialist to get a biopsy. And once we did get that biopsy, I'll never forget walking into the doctor's office. And I knew there was something, I knew there was an issue, because I called to say, I'm real busy at work. I may not be able to make it, tell the doctor. And they put me on hold, and the doctor told the woman at the desk, tell him I'll wait for him. I get there, his face is beet red, and he said, Darren, you have cancer. Not only do you have prostate cancer, you have a very, very aggressive form. I think we've caught it in time, but there's no way to tell. We have to run a whole bunch of tests. So I say that to say, of course, you imagine what you're feeling. Here's a guy who's thinking, this can't happen to me. Then I'm going through the motions because I'm going to these events. Guess what? It did happen to me. And luckily, we caught it in time, and it did not go into my bloodstream, although it was on the move. And the pathology report showed that it was on the move, and that and the surgeon and my primary care doctor thought it could get out any, I won't say any minute, but it looked dire. I had a high Gleason score. But I want to say that sometimes you have to be your own best advocate, but also when people tell you these things, we're not just saying it for our health. And it's been working. As Phyllis said earlier, the rate of prostate cancer deaths in our community is down from when they first started doing this. And because when you have these events, you tell people, especially after my experience, I made sure everyone in my family, every cousin, my brother, distant cousins, uncles, and you name it, and friends. You may sound like a broken record at first, but you want them to go out there and get tested, because you can have your life saved if you act in time. And not in every case, it's not aggressive. So that's the thing. You may go, and guess what? They check you out, and you don't have it, or if you do have it, they say, it's slow moving, and something else will kill you before this does. But you won't know until you go. You won't know until you go and start the process. So I just want to say that the organizations like AdMeTech and the Brockton chapter of the NAACP, which I've been an on and off member since 1980, since I was a teenager. And I always say this, Phyllis and Mayor, they helped me get my first job at $10 an hour when I was a teenager, and the minimum wage was $3.30. I'll never forget that. I thought that was such a big thing as a teenager. I digress, though, anyway. But I say that to say the NAACP has been an important part of American life in this country, and also here for me in Brockton. So I just want to say thank you, and that's it for now.
Darren, thank you for that. Listen, thank you for that. So can I just ask you this very delicate question? Of course, I'm not going to wait for you to give me permission. Let me just ask you. So you said I had to be my best advocate. Darren, there's too many of us out here who can't be that. And I'm going to just say, you are, Darren Duarte, a VIP. I mean, people see you as that. People see a lot of us that are on this call as that. How do you send this message out to the rest of the community that aren't you, that don't have that access, that presence? Someone, if you picked up the phone, you could say, I was mistreated. Something's going to be done about it. There are many more of us that don't have that ability. And I guess, how do we become those that are on the other side of this, or not at our particular level? How do they become their best advocate?
I think it's up to all of us. It's something that Rashawn Hall said earlier, is this talking about awareness and talking to as many people as we possibly can. You tell someone, somebody else tells someone, because at the end of the day, we're all somebody's child. Amen. We're all somebody's husband, with someone's brother. And if the individual doesn't care, I bet you that sister cares. I bet you that wife cares, that girlfriend cares, that mother cares. And if they have the knowledge, if they have the information, maybe they'll keep pressing on to that man who's in their life to make them get up and do something, to become their advocate. And maybe they will be their advocate until that man can get up and do it themselves. I really believe that, because there's a lot of strong women, a lot of strong Black women in our country who've been the backbone of the family. And in many cases, it may take them. Right. It may take them. Although my father, I'll tell you one story about my mother and my father. Although my father, I mean, I don't know if he had prostate cancer. He died of a heart attack, but I mean, he could have had it. But one of the things my mother used to always say to me, because she would try to get him to go to the doctor for a bunch of different things, and he didn't want to do it. He never would go, and he wouldn't do it. So I'd have to get on the phone and try to push him. In a lot of cases, I lived in Colorado, or when I lived in the Deep South, or when I lived in Washington, D.C., or I lived in Connecticut, and I wasn't there, but I'd pick up the phone and say, Dad, Mom's not saying this for your health. And this wasn't even about prostate cancer necessarily, because back then I wasn't, back in those days, I wasn't thinking about prostate cancer. Probably should have been, but I wasn't. But I'm glad I am now. And I'm glad that we have these resources, although, like Rashawn said, if we had, hundreds of millions of dollars like they're spending on campaign ads all around the country to get someone elected, imagine how many lives we would save, not only for prostate cancer, but a bunch of other things. But I think starting with your family, starting with your friends, and that's part of it.
Thank you for your testimony, and thank you for allowing me to give that follow-up question, because so many people, they're like, oh, you have to come with me, Bishop. I said, I can't come with you. I can't order the doctor to do certain things. I mean, I could come in here and try to be intimidating, but the locks don't work, let me tell you. So it's like, what do we do in terms of giving folks the strength? But I love what you just said, because often enough, it is a strong partner, or if our moms are alive, or a sister, or someone, a strong individual that's going to come with us and make us do the right thing. And often enough, they're better off communicating to the doctor in an intimidating way than I would be. But yeah, thank you for answering that question.
But Bishop, is something else that they could do that I did, of having the resources, among all of you, is that you start ask them when they go to the doctor, they get their scores, have them share it with you.
Oh, I love that. If
you don't have the answer, ask Dr. Stern, or ask.
I love that.
Does this seem right? Does this seem right? Or should they be getting more treatment? Should they be asking more questions?
Yes.
Because that's also key, and I think that will help. If they won't do it, and if this is someone someone you love, or someone you like, even if it's not, if it's a stranger,
you care. We care.
Yeah. So that's another way.
Yeah,
So
Tony, if I can chip in again, if you don't mind. There are a couple of things I want to point out. First of all, as a part of our campaign, a public awareness campaign, public educational campaign. We are always, not every man can be as assertive as Darren Duarte. You're absolutely right. On the other hand, every man who reaches the age of 40 can ask his doctor if PSA testing, particularly black men or other men at high risk,
Got it. Yep.
can start conversation or at least a question to ask of their doctor. Is PSA testing right for me? Okay, but I also, Tony, I'm afraid I already told you the story in the past, but let me retell you a story. Pastor Hughes, senior pastor at Concord Baptist Church in Milton, in Massachusetts. He invited us, he invited AdMeTech to give prostate cancer awareness event for men's health group in his church, which is a fairly large church and a fairly large group. And then he invited us again next year. And in my judgment, he created a model for his congregation and elsewhere. He shared that after he heard the information we provided, he went back to his doctor who never talked to him about PSA screening. And he asked to get his, in his 60s, he was in 60s at the time, and he asked for a PSA blood test. His physician gave him a song and a dance of some kind. So he got frustrated and he said, you know what? Either you give me PSA testing or you will not be my doctor anymore. And he basically shared this with his congregation. He created a model for this man. He actually told this man, his story, shared the story with the goal of letting them know, if your doctor does not support you, this doctor is not the right doctor for you. You should walk away.
Thank you very much, Dr. Stern. So this conversation requires a Dr. Stern and a Dr. I hope I said it right, Wason. And so we're going to hear from him because we need to hear from top physicians in the field. And Dr. Wason is just that. Ladies and gentlemen, Dr. Sean Wason is a faculty member of the Division of Urology and Associated Physicians, Harvard Medical Faculty Physicians, Milton Center for Specialty Care, and Needham Urology Associates. Also Beth Israel Deaconess Medical Center and Beth Israel Leahy Clinic. Harvard Medical School as well. We have a very knowledgeable and studied man that is going to tell us all about prostate cancer and the advances, screening and treatment that is happening now. Dr. Wason, thank you for being here. And I hope I didn't damage your name.
No, you got it right. Thanks, Tony. I appreciate the introduction. I've done a couple of these talks, and I always appreciate the invite and the ability to kind of speak candidly and talk a little bit about the advances in diagnosis and treatment of prostate cancer. The one thing I just did want to mention, Mr. Roberts shared his story, and I think that one key thing to know about prostate cancer is there's really two phases. There's the I would say the localized phase and then the advanced metastatic phase. And really our goal is to find prostate cancer when it's localized, because when it gets outside of the prostate, then really the treatment is androgen deprivation therapy. And what this is ADT for short. This is taking the male testosterone and dropping it to undetectable levels. That's what makes guys feel miserable when they're having, treatment for advanced prostate cancer. And so really our goal is to find prostate cancer when it's localized, when it's asymptomatic, so that you never get to the point where you need androgen deprivation therapy, an injection every 3 to 6 months to lower the testosterone, because once it's outside the prostate, it's very difficult to cure, if not impossible. We can certainly manage it, but not without significant, side effects. So I just want to just sort of highlight that particular aspect. I'll share my screen here, and let me know if you have trouble seeing it. I really just want to go over, what are the goals of screening? How do we make the diagnosis? What are some of the imaging that we're using? And then where do biomarkers play? What role do they play? I see men of all ages. They come to me with lower urinary tract symptoms. Some come with an elevated PSA. And really anyone that comes with an elevated PSA, our goal is this related to BPH, benign prostatic hyperplasia, or is this something more sinister like prostate cancer? This is a hypothetical patient that came to me. He does have a family history of metastatic disease, also a family history of, a brother that had localized disease. And so it's important to kind of look in your family history. Who in my first degree relatives, had prostate cancer? Am I at increased risk of having this particular disease? I will always repeat the PSA. You really need PSA in the absence of ejaculating for about 72 hours or any kind of sexual activity. So you want a second PSA. And then we always combine the PSA with a digital rectal exam. Prostate's kind of this gland that's about the size of a walnut. It fits in between the bladder and the urethra, and actually the urethra goes through the prostate. So when the prostate enlarges, not necessarily due to cancer, it can contract on the urethra and cause a lot of lower urinary tract symptoms. Sometimes I see men with, advanced disease that is from, that can develop lower urinary tract symptoms. Most of the time, though, when someone does complain of urinary symptoms, waking up at night, weak stream, straining to go, it's due to BPH, which is a non-cancerous enlargement of the prostate gland. And, certainly very, low risk of prostate cancer in some of those men. It's a reproductive organ, contributes to semen, but we know it develops prostate cancer in 1 in 8 men. There's really a couple different types of prostate cancer. We have the low-grade prostate cancers that, like Darren said, you can live with. It's not going to, kill you. We have a lot of men now on active surveillance where they have prostate cancer, but we don't even need to treat them. We see them every 6 months. We get a PSA. We follow them with imaging. And a lot of these men really don't need any kind of treatment. We want to diagnose the patients that have intermediate and high-grade prostate cancers. And fortunately, those are fewer than the ones that have low-grade prostate cancer. A lot of our guidelines are evidence-based, and we have several societies that give us guidelines on who we should screen. The one in the U.S. is the American Urologic Association. There's also the European Associated Guidelines, and they all have guidelines for the early detection of prostate cancer. If you're under 40, you don't need to get a PSA. If someone's trying to order a PSA, just say no. Over 40, I think that it's very reasonable to discuss with your primary care provider, what is my PSA number? Does it make sense for me? Am I healthy enough? What about look at my family history? What is my PSA? And so really, the key patients, I think, are in between the ages of 55 and 69. Those are the guys that get the most benefit of screening, but you can certainly get a PSA as early as 40, 45, because there's a lot of evidence to show that if you have a very, very low PSA at that age, your risk of prostate cancer is relatively low. Routine screening in someone probably over the age of 70, 75 may not make sense in all men, but that's something that you certainly want to discuss with your primary care provider. If they're not sure, then you should see a urologist to determine if continued screening is right for certain patients. Well, PSA, prostate-specific antigen, it's just a blood test. Digital rectal exams, very quick exam. You can feel the prostate, at least the backside of the prostate through the rectum. Screening is best in combination. And we do screening because we want to find disease when it's asymptomatic. Those tests are not going to tell you if you have prostate cancer. And there's multiple reasons why the PSA may be elevated, but you really need a prostate biopsy to make the diagnosis. PSA is a protein in semen that liquefies the ejaculate. It's only made by the prostate. So if you don't have a prostate, your PSA should be 0, but it is a good marker to determine if you have a disease of the prostate. PSA can be elevated for several reasons, and I think it gets a bad rap, but it's actually a very good screening test, because if it's high, there's something going on. Doesn't necessarily mean that it's prostate cancer, however. And I have a lot of patients that come to me and their PSA is up. Oh, but then we get an MRI, the prostate is really big. Now we can explain why the PSA is elevated. We use PSA in multiple different areas of prostate cancer and screening to make the diagnosis. We use it after treatment, in advanced disease, and also in metastatic disease. We don't typically do mass screenings. This is really a discussion that you need to have with your primary care provider. Be your own best advocate. What is my PSA? Does it make sense for me? What is my number? And then also take a look at the trend. And I've quite a few men that come to me, and I show them, hey, you've actually been screened for the last 10 years, and look at your trend. It's actually gone up over the last 5 years. And you really want to, be aware of how quickly the PSA is rising. How quickly is it doubling? Because then you can say, hey, should I see a urologist? If your PSA is under 1 and you have a normal digital rectal exam, continue at screening. If it's in between 1 and 3, likely the screening should be every 1 to 2 years. But if the PSA is over 3, or if you have a suspicious digital rectal exam, those are the patients that we want to see. There's several things that we can do just in the clinic, where we can just do a transabdominal ultrasound to determine the prostate volume. We have a lot of patients that come and they've already had a CAT scan for other reasons, and we can do a quick and dirty estimate of the prostate size based on imaging that you've had. And in patients who may have a marginally elevated PSA, they're worried about undergoing a biopsy, we can use a biomarker. A lot of these are urine-based biomarkers to determine what is your risk. I like this one particular. It's called Select MDX. It's a urine-based biomarker. And after a digital rectal exam, patient urinates. We send the urine out to a company. They'll take a look to see if the mRNA is elevated, and we look at 2 mRNA molecules, which really can help guide patients and determine the likelihood of actually having prostate cancer on the biopsy. And really what we want to know is the likelihood of detecting Gleason score 7 or more. So there's 7, 8, 9, 10, and Gleason 6. And we really want to find the Gleason 7. So if this number is elevated, then I will say, yes, I do recommend a prostate biopsy. In our practice, at our institution, Beth Israel Deaconess Medical Center, pretty much all patients nowadays will get an MRI of the prostate before a biopsy. And I think that this is really key, because you can have a very large prostate and a lesion that's anterior that may be missed on a standard transrectal ultrasound guided biopsy. So I think that this is the evolving standard of care. Elevated PSA, let's get an MRI. Let's take a nice picture of the prostate before we do a prostate biopsy to see if it makes sense. Can someone just do a standard transrectal ultrasound guided biopsy, or should we target that particular lesion? MRI is usually done with contrast, gives us a lot of information. Are the lymph nodes enlarged? Are the bones involved? Is there any suggestion that there's disease outside the prostate? So it gives us a lot of information, so we don't have to go and always do sort of a blind biopsy. And the radiologists have a sort of a scoring system that they use to determine, are the lesions that they see on the MRI, are they suspicious or not for prostate cancer? It goes 1 to 5. We're looking for the 4s. We're looking for the 5s. Those are the lesions that we absolutely need to biopsy. There's another scoring system using micro ultrasound. This is another imaging technology to determine what is the risk of having a clinically significant prostate cancer. And then this technology is continually improving, but there's different ways. You can do an MRI, or you can do an ultrasound. Most of the time, we do the biopsies in the office. If we're doing a standard transrectal ultrasound, patient is literally on the table less than 10 minutes. And that's putting the patient up in position, doing a prostate block, and injecting a nerve agent to make it more comfortable, doing our biopsy, and then the patient's walking out 20 minutes after The standard is taking 12 cores, 6 on either side, and it's going to tell us what is the Gleason grade, how much cancer is involved, where's the location, and other sort of factors that we want to know before we recommend treatment. 2 different types of biopsies. One's done through the perineal area, which is the area underneath the scrotum. One is done transrectally. Both are commonly accepted practices. And really, I think the most recent up-to-date studies have shown that there's really not a huge difference in the risk of infection with either one of these. If there is a lesion on the MRI, and especially if it's in the anterior lesion, we really want to target that. And then now most urologists will have fusion technology where you can take the real-time ultrasound, fuse it to the MRI that you've got a couple months ago, and target that particular lesion. We still do the standard transrectal, quote unquote, blind biopsies because we want to know, is it just that lesion that's involved, or could there be prostate cancer elsewhere? If the lesion's just involved, then potentially you could be a candidate for what we call focal therapy. These are just some schematics of what the ultrasound image looks like on the left and what the fused image looks like on the right. And we can really tell if we sampled the lesion that was noted on MRI. There's a variety of Gleason scores, and really you want to know, do you have Gleason 6 or less? And most of those patients are candidate for active surveillance. Even patients that have low volume Gleason 7, anything over 7, 8, 9, 10, really we're recommending either surgery or radiation. There's a variety of risk categories, but there's very low, intermediate, high, and very high risk prostate cancer. So just know that it's a very heterogeneous group of patients. Some are mixed with very low risk disease and low risk disease. These patients are not going to die of prostate cancer. Unfortunately, these are the majority of men, but certainly the intermediate, high, and very high, you need treatment. For some patients that have a very low risk or low volume disease, we can actually take that sample, send that off to get tested, and genetically we can determine what is the risk of really dying from prostate cancer, or having metastatic disease, or harboring more advanced prostate cancer. So there's a lot that we can do in patients that have Gleason 6 and 7 disease. Other imaging modalities that you may hear from: CT, bone scan, PMSA scan, and these are sort of advanced imaging that we do to make sure that there's not disease outside of the prostate. And so very clear, very important to know, is the disease localized or has it spread to other parts of the body? So if you are diagnosed with prostate cancer, what can you do at this particular point, especially if it's localized? Smoking cessation, number 1. Consider a low dose statin or metformin, and vitamin D supplementation. So all the patients that are diagnosed with prostate cancer, we check a vitamin D. We make sure that their blood pressure and lipids are appropriate, and then certainly counsel them on smoking cessation, and get them plugged into different kind of groups. In summary, prostate cancer is common. The aggressiveness is quite variable. Earlier detection is favorable. We really want to maximize the detection of intermediate high-grade cancers and really minimize the detection of non-life-threatening cancers, for which there are quite a few. And we're using imaging and genomics to improve our risk stratification. And this has really allowed us to be more comfortable with active surveillance. So thank you for your attention, and happy to take any questions.
Dr. Wasson, thank you so very much. I don't know if folks are going to jump in with questions, but I actually wrote down a lot of notes because I want to just ask one real quick question.
Mm-hmm.
Metformin, why is metformin recommended?
This was a recommendation by one of the I guess grandfathers of prostate cancer. He has actually a lot of men on active surveillance. He treats a lot of men at the University of Toronto. Professor Laurie Klotz, he's done a really deep dive into prostate cancer, and it's quote unquote wonder drug that really the insulin resistance is really, a driving factor for a lot of, prostate cancer, and to improve insulin, resistance, and especially when it comes to like the metabolic aspect.
No, thank you for that. I'll overshare. I mean, I'm a diabetic, insulin dependent, and I take metformin. That's what I was saying. I've never heard anybody connected to the prostate cancer. So I was that's interesting. I'm going to do a deep dive in it even more. Were there any other questions? All right, well, I'm going to go on and ask the magic question about the genetic testing. Who pays for that?
There's some insurance companies that will pay for it, and now there's common subspecialty genetic oncologists, and so really men that are diagnosed with high-grade prostate cancers, if they're under the age of 50, and they'll consider running a panel for certain mutations, BRCA1, BRCA2. There's a whole panel, and a lot of men, they want to know what is the risk of passing this off to my offspring. And so I think that there's some value in genetic testing for certain individuals, but most of the time it is covered by insurance.
So it is covered. So Dr. Wason, you mentioned something about, and I did that. Of course, I didn't write down clearly, and I know we're pushing for time, but I got to get this out. Life expectancy. You were talking about if someone had the prostate cancer, you could determine what their life expectancy. I could be paraphrasing. I could be totally crazy on what I'm asking.
Well, we have certain tests where you can actually take, let's say you find somebody with a small amount of Gleason 6 disease and you want to put them on active surveillance. You can actually send those cancer cells for testing, and they will run it against a panel of about 40 genes to determine, is this a more aggressive prostate cancer or not?
But a lot of folks that I know in my family, when you've told them about cancer, there's been various, and if they're like 70 years old, I can remember, Tony, I only have like maybe a good 5 years, 6 years, 8 years left. So when they hear that, they don't want any further treatment on anything. That's why I was asking about what you were talking about in terms of life expectancy.
When patients come to us in the office, and certainly had some patients that are 78, 80, and they have an elevated PSA, potentially, ordered by the primary care provider. We expect the PSA to go up as you age. And I think that you get diminishing benefits of finding prostate cancer in an elderly male, at that age. They don't really benefit all the time. They may come and they have, other symptoms suggestive of metastatic disease, but I would say that the average life expectancy in the US is about 78 years old. So the likelihood of you passing away from something, other than prostate cancer is a little bit higher.
Great information when we're having these conversations with our elderly family members. Dr. Wason, thank you. You've been awesome in your explanation. And one of the things that I always love about your presentation, a layperson can understand it. And actually build questions from it. So I was taking down some really good notes, and I hope we have you next year as well. So thank you. Listen, I know we're pushing for time, so I'm going to introduce Dr. Faina Stern, who is the president and CEO of AdMeTech. You all already know she's awesome. And Emma Hullard, she's the manager of the Prostate Cancer Equity Program and Organizational Development. Welcome to this forum. Hey, Emma, good. There you go. Good seeing you.
Hi, nice to see everyone.
I would like to thank leadership of Brockton and ACP for partnership of almost a decade that made such a big difference in Brockton, in Plymouth County. Thank you so much for helping us organize this event. And without I usually, as a matter of rule, create videos to avoid problems with PowerPoint presentations in a virtual setting. And Emma, if you do not mind starting my video. My name is Rina Stern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. My gratitude to the Brockton NAACP for a long-standing partnership that made this event possible. Dr. Rayson reviewed recent advances in screening, diagnosis, and treatment. The focus of my talk is on the AdMeTech Foundation's history and our prostate cancer programs established to lead and implement these cutting-edge advances, as well as to bring them to Massachusetts men and eliminate health disparities. Prostate Cancer Equity Program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, research, and health equity. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer, increasing age 50 and older. History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of diagnostic imaging research branch at the National Cancer Institute. In this position, I was leading development of national and international policy and related strategy and programs for the National Institutes of Health, NIH, Department of Health and Human Services, and U.S. federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound, and molecular imaging for improved patient care. We also work on teleradiology for image transmission so that we could bring world-class expertise to underserved, rural, and remote communities. As of early 90s, most women had blind biopsies. Precision imaging made it possible to see where suspected tumors were located and develop stereotactic biopsies where biopsy needles are guided with precision to suspicious areas. As of early 90s, women with breast cancer have radical surgery or mastectomy where the entire breast is removed. A procedure performed in operating rooms causing physical, emotional trauma, pain, suffering, and deformity of women's bodies. Precision imaging made it possible to proceed with minimally invasive surgery or lumpectomy, where we identify and remove only a part of the breast tissue containing tumors. These minimally invasive procedures are performed in outpatient clinics with minimal complications, pain, suffering, and costs. As of early 90s, many women, particularly Black women, were diagnosed with breast cancer in more advanced stages and were more likely to die. With digital mammography and MRI, all women are more likely to have early detection of breast cancer, critical for saving lives. Today, Black women have a nearly equal chance of dying compared to white women in many communities, particularly in a state like Massachusetts with its universal access to care. In 1996, while our breast cancer programs were well underway at NCI and NIH, I brought together the key leaders of government, medicine, and industry to outline new strategic priorities. This expert recommended prostate cancer as the next priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer is among women. Prostate cancer strikes 1 in 8 men. Breast cancer strikes 1 in 8 women. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or the likelihood of men dying of prostate cancer. However, men did not have accurate diagnostic tools that would make it possible to sort out if an abnormal screening result is due to false alarm or due to a life-threatening prostate cancer. There's no accurate diagnostic tools. Many men had either insufficient diagnosis and treatment of aggressive prostate cancer with dangerous consequences, or on the other side of the spectrum, they had overdiagnosis and overtreatment of benign and harmless prostate cancer, leading to unnecessary invasive procedures with related life-altering complications and costs. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to a prolonged hospitalization, difficult recovery, and the unacceptable level of life-altering complications. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, in sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care and eliminating health disparities. At about the same time in 1996, I had a personal experience that left me shaken. A leading clinical expert in Massachusetts, chosen by me, saw my father and determined that he had a benign and common prostate condition. However, when my dad had an invasive procedure for this condition, he was found to have prostate cancer. I was shocked that a leading expert in a world-leading hospital did not have diagnostic tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of this disease for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I organized other leaders of medicine, and we approached NCI and NIH, key leaders, in a hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track record and a year-long effort, we did not succeed in convincing federal government. Consequently, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. Since 1997, we have been leading a pioneering research that resulted in creating precision MRI, molecular imaging, and other diagnostic tools that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, Where is Manogram? Prostate imaging for men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, a leading health disparity, and public health priority. By 2013, again per our advocacy, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a standard in patient care. Since 2014, we expanded our efforts in public awareness, reaching countless men. At that time, Plymouth County had the state's highest mortality in Black men and the highest disparities. Black men in Brockton and Plymouth County were 2.7 times more likely to die compared to white men. We joined efforts with Brockton NAACP and Good Samaritan Medical Center. Under leadership of Steve Bernard, Phyllis Ellis, Leona Martin, and Janet Trask, Brockton NAACP ensured a broad community engagement, mayor's office, city council, local media, and multiple local community organizations. By 2021, we had seen a significant reduction of overall prostate cancer mortality for all men in Plymouth County, but a particularly great impact on Black men. Since that time, we have seen a significant drop in health disparities in Plymouth County, while health disparities at the state level have not really changed. Today, Black men's chance of dying of prostate cancer compared to white men in Plymouth County dropped by more than 50%. In 2016, we established Global Summit for Medical Education with the goal to integrate imaging with other emerging diagnostics, including molecular and genetic testing, to ensure precision care that was tailored for individual men. Similar to breast cancer, precision imaging paved the way for image-guided, minimally invasive treatment for prostate cancer. Similar to lumpectomy, these minimally invasive procedures can be performed in outpatient clinics with minimal complications, discomfort, and cost. Several years ago, in 2021, we created Prostate Cancer Equity Program to deliver high-quality, world-class patient care to all men in Massachusetts, with the priority focus on Black men. The centerpiece of AdMeTech's medical education is annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. There is not a corner of the world that has not been represented at our summit. The latest 8th annual conference took place only a few weeks ago. It was interesting to hear at this year's summit from multiple experts that of all diagnostic tools, imaging has become the game changer for men, resulting in improved diagnosis and treatment of life-threatening prostate cancer, while decreasing unnecessary biopsies and treatment. For example, in this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research and development and large-scale implementation of prostate MRI since 1997. In 2013, Massachusetts legislature funded clinical trial of prostate MRI, which produced groundbreaking data that were presented at Summit 2016. By early 2017, about 6 months after our first summit, MRI was recommended as the new standard of patient care prior to biopsy and treatment. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard line biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics, MRI and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of cancer progression. Emerging data indicate the importance of genetic testing for many high-risk men, Black men in particular, for selecting the most effective treatment. With this precision diagnostics, we can now accurately determine if each individual has a slow-growing, so-called harmless disease and needs only a careful observation or minimally invasive procedures, or an aggressive prostate cancer requiring immediate life-saving intervention. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, molecular imaging with PSMA has become available at the Dana-Farber Cancer Institute since August 2021. On the left, right here, we can see a traditional bone scan showing no metastatic spread. However, on the right, molecular imaging shows multiple areas of metastatic spread. This information is important for selecting the most appropriate treatment. We are proud to have led research and development of molecular imaging since 1997. Our summit concluded that equal access to high quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and multiple branches of NACP located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities, particularly when combined with our large-scale public education and awareness campaign. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in our program take care of our families and friends. This process consists of three main components. First, AdMeTech Foundation team members collect basic information and match individual patient needs with the appropriate state experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, and financial assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech team. When you come to us, Emma will work with you, our team, Masjema, Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@AdMeTechFoundation.org. Thank you for your attention. Tony, do we have a minute for Emma to say a few words?
Sure, I'll be really quick because I know we all want to get to other things we have to do. But as Dr. Stern mentioned in that video, I'm the first person that you would talk to if you contact the Prostate Cancer Equity Program. So please, our call to action tonight is if you or anyone you love has any concerns or questions or would like a second opinion, please reach out to me. I'm going to put the phone number and the email in the chat, and I'm there for you every step of the way. And our experts are amazing. And it's just a great program. And please reach out if you have any questions or concerns about the program.
Thank you, Emma. Back to you, Tony.
Well, listen, I appreciate you, Dr. Stern. Thank you, Emma. Thank you. We really need to wrap up. I know you all, if you haven't eaten your dinner, you need to go do that. But this was a very, very important event, and I want to bless this partnership between AdMeTech and the NAACP, specifically Phyllis, to your leadership. Thank you, thank you. Thank you all for all the testimonials. Thank you, Dr. Wason. You were just awesome as always, and all the other partners that are on this call. We are the NAACP Forum with AdMeTech this evening, and I want to leave you with this. Thank you for joining us on this mission tonight. Let us turn awareness into action and hope, because this is a life-saving event. God bless you and good night.
Thank you very much, everyone. Great evening.